Thank you, Sajid.
Good morning. Good evening, Kyo.
Yeah, good morning.
Hello.
Uh,
Hello, everything. All okay? Kyo, thank you very
yeah,
much.
thank you so much. Thank you.
Hi, William.
Thank you so much, with Professor William.
Oh, yeah, I can hear you.
Hello.
Hi, David.
Hey,
Davide.
William.
Hey,
Hey, how are you?
okay.
All okay? Fantastic.
Yeah, one thing I have to tell you is that the workshop in Bali.
Oh, yes.
Too many workshops.
Yes. Yeah, you just tell them, because all master class is no word. It's like a conference.
Yeah,
So because there is only one workshop is hands-on, the rest is all workshop, all lecture. So
we
it's
don't
not
need
really, yeah, no need that, because you can have during the conference.
that.
Yeah, you can tell them directly, no need to worry. You can just
Yeah,
tell them.
okay. Yeah.
Just tell them. Very difficult to make them change. Anyway, this will be the last one. From now onward, I think we have decided that Elsa will take over and will organize the meeting. Finish. We are, because every year is the same
I
problem.
told you before.
Yeah, every year the same problem is the same issue. We need to look for money. We need to do the program. We need to do everything. Just better do ourselves. Finish.
Yeah.
We actually we try. Impossible. We will discuss in Bali.
Okay.
How is the life? Antonella, you happy?
Yeah, she's happy,
Okay.
but yeah, she's too old to learn,
Yes,
to
it's too old to learn.
adapt to. Yeah, but I try my best to tell her what to do.
It's okay.
And
She want to.
I let
She
I
was.
let her hands on. Was she happy?
want to. She's happy. I
Give
don't
me a
know.
while. I'll
I
join
need
you
to hear.
guys. 1 minute. Can
Hey, hey,
I'll join you in a
no
while.
problem.
1 minute only. Okay.
Why
Why
are you using
joining me in 1
Sajid?
minute?
Why are you using Sajid, Malik?
I think, Prof, you need to log in from your account and then it will show your name. If you directly use the link without using your account sign in, then it will show my name. It's the same link basically.
No, I use my account. No, Gafur he need to use the panelist account.
Yeah, exactly. And if you use your own account, like Kyo is using his own account from the panelist, so it will show his name.
Okay. Anyway, Zoom has a lot of new feature now. A lot of new things. So I will pass the host to you, eh?
Yeah, and then I will pass, maybe not to me, Prof, maybe to Kyo, because I will omit myself, just Kyo, Gafur, and Prof. They will be connecting it.
Yeah, you can.
Because I am, what do I do? I am, who are you? With video, background, video filter, advanced. I'm doing what I'm doing here. Because I'm using the phone.
Okay.
Because I was driving actually. Webinar, backup, live stream, use connect, YouTube, poll. Do you log in the? Do you log in?
Yeah, I am.
No, you can make cost.
Yes.
Kyo.
But
You
I'm
make
logging
cost
from my
Kyo.
account. I'm logging from my account, not from yours.
No, you should log in with my account.
Okay, I'll log in from your account then.
You log in with my account, then you make because I am with the phone, so I have no clue how to.
Got it. Let me do it.
Background participant Zoom. Okay. Share option. I put also activate the caption, in case you need.
Yeah. Just
webinar setting.
I'll do it from my. Yep.
Allow.
it's
Okay.
moved.
I approve. I just
Okay,
approve.
got it. Yep, got it.
Okay, now you are the host, okay?
Yep, okay, great.
You put your, you can put two hosts, you and Kyo.
Yep, let me progress. And
Do you have you prepared all the question for from William for William Kyo? Very difficult question.
No, no, it's simple questions. Everyone want to know about you, about your career, about your how you develop your skills,
Okay.
everything like that.
Yeah.
Okay, can we start?
I think you can start.
Yeah,
You
Gafu
need,
will come.
because now we are in a waiting room, she can start the webinar now.
Yeah. Okay, let's start.
Okay, good luck. Thank
Thank
you.
you, thank you, thank you, Prof.
Thanks, Dave.
So, hi everyone. I would like to start our ELSA fourth webinar, fourth live TV show. Today's special guest is Professor William Chen from Taiwan. I am Kiyotaka Imamura from Yotsuya Medical Kyum, Tokyo, Japan. And today I'm very honored to be here as an interviewer. And I'm very happy to have Professor Chen here today. I would like to introduce Professor Chen first. Is it okay, Professor?
Yeah, sure.
Okay. Okay. I'm very happy to introduce you. Professor William Chen is currently the Superintendent of China Medical University Hospital, Hsinchu. After earning his medical degree in Taiwan, he completed a research fellowship in colorectal surgery at Cleveland Clinic in Florida. Utilizing his training and clinical experiences, he has made notable contributions to literature regarding cutting-edge technology of colorectal minimum invasive surgery. Dr. Chen is also a charismatic speaker, and along with serving as clinician and researchers, Professor Chen is currently an associate professor in Department Surgery, School of Medicine at China Medical University, Taichung City, Taiwan. Okay.
Thank you. I have to make a correction. I'm now a professor of surgery, not associate. I think that was my previous CV.
Oh, sorry. Sorry.
Yeah.
I took the wrong old one. Okay.
Yeah.
Today I'd like to ask you about your how you develop your career, because everyone want to know about you and how you make such a great contribution to the minimum invasive colorectal surgery.
Well, I think my career of colorectal surgery, please excuse for my voice because I had a cold. I had fluid the past few days. I started my career as a surgical resident in a country in a south side of Taiwan. It's located middle south of Taiwan, which is a small hospital. We began it with as a regional hospital and become a medical center after all. And then I spent my first 15 years there as a resident, as a attending doctor, as a chief of colorectal surgery. And I think it was back in 1997, 96 or 97 when Taiwan hosted the colopathology meeting of Asia in Taipei. I met my mentor, Steve Exner, and I asked him if I could go over for to spend a period of time there. So fortunately, I was be able to go for 7 months in Florida, and I came back and become the chief of colorectal surgery. At the time, about my first laparoscopy, I started in 1999, January 6th. I still have the pictures, and I still memorized the first case that we done was the benign case, and it was a total colectomy, subtotal colectomy, and it took me 9 hours of time to finish it. And what amazed me was that I did not convert. And then the patient discharged it 5th day after the surgery. So that gave me strength and power to continue on my laparoscopic work at the time. And then I joined China Medical University Hospital. That was my alma mater, and I was recruited back to our school to develop minimally invasive surgery. And till then, I become from an assistant professor to a professor now. And what I think I learned the most during the year is to join ELSA. ELSA is where I got all my techniques got improved, and I also made a lot of friends through ELSA, the platform of ELSA, which Michael Lee, another good friend and as well as a mentor to me, brought me into the society. And I think ELSA has shown me a lot of things doing over the years that I've been participated as a member and also as a board member of the society. So, and developing a good minimally invasive platform is probably, you take some perseverance, and you need to have a lot of resilience to become a good surgeon. And also throughout the year, you have to have good friends. You have to have friends to help you. And I think I have many good friends through ELSA. So this is, I think, a brief introduction of me. Yeah.
Thank you so much. There are many questions regarding to your talk. Yes, last night I was surprised because your so many chapters of textbooks, many authors of textbooks, and even the ELSA manual. It was over 120 million downloaded. So
Yes.
we are very proud of that. And you did a great contribution. And I have many questions from my friends. Some of them are trained under you before.
Yeah.
And I gathered many questions from them.
Yeah. Hi, Q.
Yeah.
Hi, Prof. How are you all? Okay.
Hey.
Hi. I would
Sorry
like
for
to
coming in
introduce
late. Just swamped with a bit of
Apollo.
work last minute. Yeah. So sorry.
Okay.
I think I want to start off a bit, Prof, with a bit of background from you, from your schooling days a bit. So what made you want to become a surgeon actually?
Well, I become a surgeon actually was by coincidence.
Okay.
I didn't want to be a surgeon. I was a urologist. I was in urology training. But then after 1 year of urology, I was kicked out by the chief of urologists. I got into a fight with the urologist, the chief of urology, so I got kicked out. And then I applied for surgery.
I see.
applied for surgery back then. So that was by coincidence. Yeah.
I see. You didn't want to do surgery, but by chance you got into surgery because you got kicked out of urology.
And I didn't want to go into colorectal surgery as well. I was aiming for hepatobiliary surgery. I want to become like a transplant surgeon or a hepatic surgeon. But I ended up with the colorectal surgery, doing a 3D surgery, which is difficult, dangerous. And 3D, difficult, dangerous, and dirty. Yeah.
Difficult, dangerous, and dirty. Yeah, that's the thing. Yeah.
So I wasn't even supposed to become a laparoscopic surgeon. I was. My dad is. I'm from a small town of Taiwan, which in down south in Changhua. And I wanted to go back and join my dad for his practice at the time.
Right.
And then I ended up with doing laparoscopy for the rest of my life, which is
Yeah. You think you would have been happier joining back your dad now, retrospectively?
Retrospectively, yes or no? Yes,
Yes
or
or no?
no?
Yeah,
If I would join my dad, I'll be probably retired by now.
yeah,
Instead
yeah,
of
yeah,
staying in the hospital, still struggling,
yeah, yeah, yeah. I
and
can
still have
imagine.
a lot of debt
Yeah,
to
yeah,
pay, mortgage to pay for it. Yeah.
yeah. And Prof, can I ask you regarding your training experience? Because I know you trained in the States, and I would like to ask you about what influenced you to choose the States to go and train at the time, and whether or not you feel that the training now in Asia can match that particular training, and what are your thoughts on that now?
Well, I was thanks for training in the state. I think the most I learned in the state is not surgery itself. I think that the most I learned is how to organize the colorectal team and
Right, right,
how to become academic. I think Steve Exner is one of the best in this, and
right,
how to collaborate with the others. I think
right, right,
Steve Exner is the best in this. And what I learned, back in the state is different from now. Where I mean, I'm a baby boomer as well as an X generation. So
right,
it's different nowadays with the kids learning. It's different from us now. It's
right,
different from me at the time we were learning. We were learning the hierarchies, way of surgery.
right,
So, uh, per se, I mean, to learn what I took from the state now was how to organize the team, how to
okay,
team up with the team. Now that
okay,
in Asia is different. Everyone here in Asia is skillful.
right,
I mean, I think in Asia in general, we are skillful
right,
in terms of hands, but we're not doing a lot of academic work. We're not doing a lot of writing. We're not doing a lot of publication, or we're
right,
not doing a lot of study together.
right,
But in
right,
the Western world, they would do randomized trials, they would do multi-center trials, and that we don't. In Asia, we're more like I'm the best, so you're inferior to me. And everyone has his own kingdom.
right,
So,
right, right.
but for surgical technique in concern will be, I think Asia is a bit superior of the Western world. Yes.
How do you think we can bridge this gap, Professor? Because like you said, this Asian culture of having your own kingdom, and I want to do only what I want to do. I don't care what the rest of you do. This is actually a very big gap between us and the West, and I find that when you try to adopt that culture of scientific paper writing and things like that, it's difficult to amalgamate this into the Asian mentality and culture. But what do you think? How do we kind of slowly try to introduce this into our system and
You
try to get
see,
the
we
best
do it
from both worlds?
for the past few years. Davide and I are working on collaboration. So we have
Right,
the ELSA textbook,
right,
the ELSA
right,
textbook.
right.
With the ELSA textbook, it takes a lot of efforts to do so.
Yeah,
You need multi center. You have to have an organizer,
yeah,
and unfortunately, and it's so sad that the one of the author passed away, Mary Lou.
yeah,
She
yeah,
passed away
yeah,
from kind of cancer, breast
yeah,
cancer, I believe. Yeah,
yeah,
but
yeah,
this is the way that we connect people, like
yeah,
having people writing chapters and having people sharing their techniques, and I think
yeah,
that's a way of the beginning. And then I
yeah,
also do a lot of currently I'm doing another study with Singapore and Japan together.
yeah,
We can do it because we're so close as a country. We're so, I mean, easily to get to the country by at least, I mean, at the longest maybe probably 6 hours or 3 hours, 4 hours
yeah,
to get there. To get to
yeah,
Malaysia, it takes me 3.5 hours or 4 hours.
yeah,
So
yeah,
we're so
yeah,
close, it's so easy to stay. So
Yeah.
actually, we can do more study in terms of collaboration. This is what I
Yeah.
think.
Yeah. So that means you feel that there needs to be an initiative by a society or a group to move it, and then the collaboration will occur around in the
We
region.
have to have a platform. So
Yeah,
that's what
yeah.
I say in the opening, that ELSA is a platform for me
Yeah,
to gain my experience, as well
yeah,
as I myself to get known.
yeah,
I
yeah,
mean,
yeah,
I thanks ELSA for providing me the platform for
yeah,
me to become a more of a known person around
yeah.
Asia.
Yeah. I totally agree. ELSA has opened up doors for a lot of people, and in all segments of generations, seniors,
Yes,
in the middle, juniors, and they have this culture of encouraging newer people to come up, and it is something that when we replicate in our own system, it shows a lot of benefit as well. Can
yes,
I can I pick your brain a bit on this, on how do we now I mean, you basically are a 99% laparoscopic surgeon before. Now maybe you're a 70% laparoscopic, 30% robotic, or you're something like that.
yeah,
The ratio is around there, Prof. I'm right? Maybe the ratio is
yeah,
around there.
yes,
Yeah,
yes.
ratio is around there. Okay, great. How do you, and still around Asia, Professor, I'm sure you realize that the uptake of laparoscopy is still not so prominent. And the reason, I'm sure you know, it's not because of money. People have money to buy laparoscope towers, and they are available, but still the procedures specifically related to colorectal is not being done at the pace and at the penetration that it should be. So what are your thoughts on this actually, and how do you think can we bridge the gap more?
Yeah, this is something that's important to all of us know, that by teaching the next generation, where we have to teach in a different way. See, nowadays the kids, they are smart. I mean, we're teaching the millennium, the Y generation. They wanted to relax. They wanted to stay away from hard work. They just wanted to be relaxed. And then how can you teach them into uh someone who is conscious and competent?
Yeah,
How? I mean, we have to go through probably three ways of it. One is cognitive. First of all, you have to go through cognitive. You have to show them what is this, and you have to let them know what is this, and you have to let them know what the procedure is. By knowing this, you can bring them from unconscious incompetence to conscious incompetence. The next step is to associate it. You have to have a lot of platform for them to work on it, such as a simulator, or you train their skill motor. You have to train with dry labs. You have to make them work it over and over, repeat and repeat, to become professional. So you can bring them from conscious incompetence to conscious competence.
right,
And
right.
then the last step is autonomic stage. It's you let them they do it. You speed up, and then they know how to do it, how to solve the problem, and that will become what we call unconscious competence.
Right, right,
So
right.
dealing with these people, we have to have a different way of showing them, not just slides and reading
Right,
textbook. Nowadays,
right.
they don't read textbook. You have to
Yeah,
show them video. Video
yeah,
probably would be one of them. Second of them is podcast.
yeah,
And you have
yeah,
to
yeah,
flip, and you have to teach them in a flip class,
yeah,
flip classroom. It's a
yeah,
different way of teaching. So if you
yeah,
bring textbook and slides there, they probably would kill you.
Yeah,
Yeah.
yeah.
And then also you have to tolerance using their phone doing your talks or doing your lectures.
Yeah,
Not
yeah,
because this is something that they use,
yeah, yeah.
in their daily life.
How,
So this
how,
is yes.
how about the intraoperative teaching? Do you have any tips for generation Y?
Yes, intraoperative teaching, I also classify into 3 categories. First of all, you watch me to do surgery. You understand of what I'm doing. So this is a cognitive way of doing it. Second is I'll let you go up. I'll tell you to do a specific procedure. Within 20 minutes, if you can't move on, done for the day. Okay? You're done for the day. And then the next time you come up, you start it and the same thing again. If you can move on, keep going on. If you keep going on until you stop for 20 minutes, and then I'll step out. You'll have to step out, and I'll do the rest of the procedure. Okay, and the third stage is I'll let you start it from the beginning, and I'll sit right behind you. I'll tell you what to do. Just do it the way I said. Follow the direction. If you cannot follow the direction, then you're out of the game. So this is how I teach.
Right,
How,
right. So,
how,
yeah.
can I? How
Yes.
many international fellows are you accepting per year?
Per
Because I
year,
met many people from in the world, in the Asia.
currently I have 3 with me. One
Mhm.
Malaysian who's leaving next week, and one Indian, and the other from Mexico. A girl from Mexico just arrived today. So usually we'll keep about 3 to 4 at the same time.
So totally how many per
Per
year?
year,
Or three?
probably, because usually I take only 6 months to 1
I
year.
see.
So
see.
uh
20?
excluding the observers, I probably would take 4 to 5
Wow, too
because we
many.
have massive numbers of
Yeah,
cases. We have 1,000 cases in just one site, and in my site we have about 300. So it's enough for a fellow to learn. And my point is, I will let you hands on under
Yeah.
my vision, and
yeah,
that's under my vision. I'll let you try it a little bit.
Yeah.
This is different from Japan or US or Korea, but
Yeah.
under the permission from the hospital.
I
So
see.
I'll give you a hospital permission that you can hands on.
Yeah. I was one of the lucky ones, who had this
Yeah.
opportunity.
That was you were here when we started the
Yeah, I
program,
was
but now the
very, I
program
was,
is more strict now.
yeah, I was very lucky when I went for 30 days with Professor William. Let me just maybe share with the young surgeons who are watching this podcast. This ELSA TV podcast. Um, the the structure in which Prof William runs this is you have to follow it his way. You have to. It is that there is a structure to how he does things, and you have to trust the process. And if you trust the process, then the outcome generally will be a successful one. So the thing about the entire team is they all trust the process. So when you come into it, it's like you are joining a military garrison regiment that is already tuned to follow the way that it is, and the general is Professor William. So you follow, and and the
Now we
generals.
have many. We have many generals now.
Oh, now many. Yeah, I can imagine.
Yeah.
So you follow. So I think it is very it really applies, and it really listens to the soul of Asian trainees, because we are generally very, I mean, obedient kind of culture, you know, especially when it comes to structure. So we go very well in this kind of situation. So I think you have the cultural benefit of training in a facility that uses Asian culture in terms of structure and following the right way of doing things a specific way on one side. And you also have embracing technology and new ways and the best ways of doing things on the other side. So for me personally, I feel that the marriage of these two is what I learned when I went to Professor William. And I think many people seem to go to places that have got one, but not the other. Maybe they have technology, but not the structure, or they have the structure and not the technology. So I think this would be the way that I look at it. What do you think,
Well,
Prof? You agree with me?
well, thank you very much for your nice compliment. But well, I just try to provide a better platform for the
Yeah.
trainee who comes in here day to day, and we need to have more regulation on our fellows, and some of the fellows are doing well, and the other are
Yeah.
not.
Yeah.
Sometimes it's all because of their the aggressiveness of a fellow. For
Yeah.
example, Isaac Shaw from Singapore General, he was with me for a year, and he has 6 publications
Right. Right.
in 1 year, and he learned tons of surgery back home, and now he's doing very well in this
Right.
institute. And then
Right.
we have fellow who comes and when he returned or when she returned, she did not even perform any laparoscopy. So
Right.
this is
Right.
I mean, we need to find a way for them to be professional.
Right.
So this is what I'm constantly thinking about it. Yeah.
Right. Right. Um, Professor, I also know that you not only set up the largest colorectal unit in Taiwan, but you also set up another hospital that is 2 hours away from where you are at. So, can you share with us that experience and what actually drove you to set it up there, and also what were the challenges that you faced to do it basically?
Well, I mean, for me to leave like a nice medical center and I mean, everything there is already set, and to go someplace that I don't know, that I never been to, and
Yeah.
then I'm in a place in Shinzu, which is and a place with a different ethnic, which is
Right.
the Hakka. It's a Hakka. It's more of a Hakka city, and
Right.
they speak a different language than I am. Although, I mean, our national language is Mandarin, but in there they all speak in their mother language, which is Hakka.
Hakka.
Yeah, so it's really a challenge for me. And 5 years ago, I think 6 years ago, we went there to build up a hospital, and the hospital was built in 20 months, which
Yeah.
is really fast. And then to set up, I bring 42 physicians with me, and about half of it is surgeon, half of it is internist. And now we have 100 and almost 150 physicians right now in 5 years. And it's a 500-bed hospital, and it's more of a community hospital. But we do something that I want to do and something that I don't do, which we do cancers only for colorectal and breast cancer. These 2 cancers are easy to treat. You don't need a lot of backups or a lot of things. You can do it just there with the radiologist or radial oncology, and also chemotherapy. We can do it by ourselves or by oncology. Also, breast cancer as well. So I learned to set up the hospital by doing what to do, what not to do. We don't want to do liver transplant. We don't want to do like heart surgery, difficult heart surgery. Yes, we do the cabbage, but we don't do difficult one. We learn to set up some centers like hernia center. We have bariatric surgery. Okay, we have cardiovascular surgery center, just doing stent, and we have nephrology is doing hemodialysis, and we have PE center is doing health center. Other than that, we don't want to do, and we also do diabetics. We want to do something that's serving the community only. We don't want to do something that's very extreme, high end of medicine. No, we don't do that. We just do community hospital, and we want to do the best quality of surgery that we can to serve the community, the patient now. And now the hospital has grown from a very small hospital now is a pretty much well-known hospital in Hsinchu. So I think when the strategy is right, I think everything will go well.
Yeah. Thank you. And I want to ask you this because I find that you have a vision in your mind and there is a strategy that you formulate, but you need to convey this vision and this strategy to people that may not share this vision, and people in our profession, you know how big their egos are. So how do you actually make them share this vision, and how do you make them join you? Actually, this is something that I really admire about you, and I really wanted to ask you how you do this.
Okay,
Actually,
let me tell you this. In 5 years, we only add physicians. We have maybe less than 5 physicians left from the hospital. So this is something that you don't bullshit this guy. Excuse me for my language, but you have to do what you say. What you say, you have to stick with what you're saying. You have to be honest with the physician.
Right.
Okay. What you promise of recruiting, for example, when I recruit Mina Shane, was one of them. Now she's my co-chair.
Right.
And she was a famous colorectal surgeon in around this area. Yeah. She works for the Taiwan National University Hospital.
Right.
So, and I recruit her. I said, okay, Mina, when you come over, I think not just money wise, not just how much I'm gonna pay you is better, but I'll give you a Da Vinci, and I'll let you do something that you are not doing it. So when she came over, so we got her a Da Vinci. So everything I promised her, I fulfill. So when I want to recruit somebody, I want to tell him or tell her something that I can do, that I'm able to do, instead of I'm drawing a picture, and at the end of the day, it's just a picture. I want to turn the picture into reality. So this is how I even talk to all my employees. I mean, I communicate with all my employees they can communicate with me anytime they want. Even a small janitor you can communicate with. So this is something different from what I do in surgery. I have to know how to manage people. But managing people is hardest, that's what you're saying. But being true, showing your honesty to your employee, it's something that a lot of many of our older generation are not doing it. They probably will say something and they say, oh no, I mean, because of this and that. No, I don't do that. If I want to tell you something that you ask me for it, I'll promise you for it, then I'll do it. yeah, I'll fulfill my promise. That's
Right.
something that being honest to my employee is important.
Right. I can understand that very much, Prof, especially coming from you.
Well,
I really do. I think Kyo has some questions regarding training.
Yeah,
Yeah.
I'm teaching laparoscopic suturing everywhere in Asia,
uh-huh.
but the young people are focusing more on the robotic surgery now. We are
Yes.
living in the transition period. So what do you think about the robotic surgery? Advanced laparoscopic surgery is we need to still run the advanced laparoscopic surgery, or robotic will replace it in the near future. So we don't have to run, for example, advanced suturing skill like that.
Well, this is a very difficult, very difficult question from you. Is that, currently I'm a fan of robotic surgery. I'm currently addicted to robotic surgery. So I do robot as many as I can. But still, when I go back to laparoscopy, I think it really helped me. Now I'm a much better laparoscopic surgeon than I was 2 years ago, because I learned the anatomy from robotic. I learned where to dissect, where not to dissect, where can I go, where can I not go. And then when I go back to open surgery, just like this morning, I did an open right colectomy. I think I'm amazed myself. I mean, I'm much better than before in open surgery. So it's three together that makes you a better surgeon, not just doing one robot or just lap or just open. I think you should put three of them together. And in the future, of course, it's going to be robotic surgery. I mean, no doubt. But we have to learn laparoscopy. We have to know how to do open surgery. So this morning I was teaching in a center back in Taiwan, because I have a case that I was asked for to do, because she is simultaneously will receive a liver transplantation. So we do it openly, simultaneously, and this is an outlier surgery, but it's one of my friends. So when I do open surgery, I found that, hey, I'm better in open surgery now as compared to the time that I was doing open surgery. So robotic surgery certainly make you see better, and it can work better. And then you come back to laparoscopy, you get better. So just when I do laparoscopy, you go back to open surgery, you got much better. Now do robotic surgery, go back to open surgery. I think amazingly you get better, because you recognize the plane, the surgical plane much better. So this is my point of view. Yeah,
Yeah,
it doesn't matter if the kids wanted to do robot, but robot is it's gonna be where it's gonna be here to stay. And how to train them? Are they gonna? I mean, are they gonna avoid doing laparoscopy and directly to robot? I think they should learn three of them: open, lap, and robotic surgery. But you have to know that not everyone can perform laparoscopic surgery like the Japanese does, because you have a very strict criteria in Jesus of validating your surgeon. But if you look at Southeast Asia, it's just a developing country with a lack of health resources. It's really hard for a surgeon to be operated like the way the Japanese or the Korean, or even in Taiwan. I mean, we are trying to set a standardized way of training. So it's very different in terms of training concept. But gradually, if you look at how I train the Malaysians, for example, all these Malaysians came over for a year. They were hands-on, and when they go back, they become a much better surgeon, and they spread their technique. For example,
it explodes.
Krishnam is one of the
Sabah.
example. Yeah, and the other was Elaine Ng. They're both are spreading our technique, and they're penetrating the Malaysian society. So I think they're doing so well, and for them to catch up, they will catch up very soon. So I personally spend a lot of time traveling in the Southeast Asia to teach, or to have the fellow to come. And now in Hsinchu, we provide fellow a free dormitory. So if they come, because I know how, when you're away from home, you're gonna have homesick. So you have to provide them a better environment for them to stay. So I think I have to take care. I have the responsibility of take care of them. So I don't think the kids should miss lap surgery or open surgery. I mean, so we have to perform some open, some lap, and some robotic. But the most important thing is to set up a unique program for them to follow.
Do you think there'll come a time when they only need to learn open and robotics? Do you think that you don't think so? There will still be a big group that will still require laparoscopy.
I think so. I mean, laparoscopy is, I mean, for example, like you said, 70% of my work are done when I do a robotic colectomy, is doing something that I enjoy though.
Yeah.
Okay. But actually I can do a laparoscopic colectomy.
Much faster.
Faster. Yes.
Yeah.
No. You can do it without spending so much money.
Yeah.
But I'm doing it because I like it. I want the feel. I like the feel of it. And patient has the money. Patient asks for it. I never denied of it. But honestly, lap is a perfect weapon.
Yeah. It's like the AK-47, It doesn't jam, it doesn't rust.
Yeah, you know that well.
Yeah.
But for rectum, for rectum, I think robotic is a must.
Right. Yeah, I can imagine.
Yeah.
I can imagine, Prof. This cost that you mentioned, Prof, regarding this robot and laparoscopy, you think that in the future, will this cost seem something that we don't talk about anymore? The robot cost, because at one point, I'm sure you remember the days when they were talking about the cost of laparoscopy versus open, and now we don't talk about that cost anymore. So I don't know. Do you think that this is going to happen? That for 4 years down the road, we won't be talking about how expensive robotics is?
Let's make a prediction. Do you think it will? In 4 years down the road, how many robots?
I think we will still be talking about the cost. I think so.
How many robots are installed in Malaysia now, as compared 2 years ago?
Yeah.
2 years ago, there was only 2 robots.
2. Yeah. Now there's 17.
Right?
Yeah.
Now you have 17.
Yeah.
Ask yourself, how many robots are there in Japan?
600.
Must be 600.
Right. So I want to ask both of you, what is your point of view in robotic surgery?
I think I agree with you that there will still be role for that perfect weapon, which is laparoscopy. We will not come to a stage, my prediction is, we will not come to a stage where down the road, 5-10 years, we stop doing laparoscopy. I don't think that, for example, what happened in gallbladder, we stopped doing open gallbladders. Now all our gallbladders are laparoscopic. But however, having said that, some procedures, because of the nature of how the robot is for them, I think it will only be for robot. For example, rectum. I believe that the robot will be the only tool that we are going to use for the rectum. Now, in terms of cost, when we are comparing open and laparoscopy, the difference is maybe 50% to 60% more. But when we're talking open to robotics, you're talking 300%, 400% more. So the margin for this is, I think, very big. So I still think that we will have this discussion regarding cost of the robot in many, many years to come. So that's my take on it. I'm not sure. Kyo, what do you think?
Yeah, I think robot must be nicer, but I don't have a robot, so I cannot use it. And also my patient cannot afford it. So the opportunity is very, very limited, even in Japan. I'm a hernia surgeon. Hernia, we cannot use robot.
But you have 600 robots there, Kyo. Don't you think that?
Yeah,
Well, but they
the-
reimburse for gastric cancer,
yeah,
right?
yes, I
They
think.
reimburse for rectal cancer.
Yeah,
They now
Yeah.
even reimburse for colonic cancer.
yeah,
So there's a way of they're doing it for advanced surgery.
Yeah.
So but in our country we reimburse I
Yeah.
think 47 procedures.
Right.
But
Right.
the procedure they're paying laparoscopic fee.
Yeah. Yeah.
And down in the road, I think I believe that. I certainly believe that robotic will be the trend of
Yeah.
surgery
Yeah.
for the next generation. Because the
Yeah.
next generation, they are technology savvy. They
Smarter.
are they are smart. They are in the era of smartphone. They are
Yeah.
different
Yeah.
from us.
Yeah.
See,
Yeah.
I'm a boomer and in between boomer and X-ray generation. I
Yeah.
follow the rules and I don't
Yeah.
mind if my mentor yelled at me. But
Yeah.
these Y and Z gens, you can't yell at them. Okay,
Yeah.
they'll post it on the social media.
Yeah. Yeah.
They'll
Yeah.
they'll videotape you and they'll put it on the social media.
They will edit it first.
Yes.
Ah. Yeah.
So it's different. It's very different.
Yeah. Yeah. Professor, we have maybe there is a question here
Yeah.
by Chris, your previous mentee, the guy who used to be there with me, right? So he said,
Yeah.
"Good evening, Prof. and Model. Just want to ask if you think there is a benefit for the patient if we do robotic surgery rather than laparoscopic surgery. The clear benefit is for the surgeon or for the patient during the operation."
Okay. If 5 years ago, I'll tell you the clear benefit is for the hospital. Okay. But
Yeah.
now, if for certain surgery, such as robotic low rectal cancer surgery, I think it's
Yeah.
for the patient. I
Definitely.
think it's truly for the patient.
Yeah.
Because
Yeah.
you can see better.
Yeah.
You can
Yeah.
do better.
Yeah.
Once you can see better, you can do better. The
Yeah.
patient's outcome will be better. I discharged the patient 3 days after surgery
That's incredible.
using a robotic. And
That's really cool.
yeah, it's incredible. And
Yeah.
and I'm constantly getting better with using the robot.
Yeah. It
But I
sounds great.
know, yes, but now I teach laparoscopic differently now than the way I
Yeah.
used to teach.
Yeah. Yeah.
So Chris, if you have time, come over.
Yeah, this will
Or
be
fly me in, I'll show you the better way.
this will be a good idea. Professor, if we have about
Yeah. 10
10 minutes more, I think
Okay.
we want to focus on a few things because there are many young surgeons who are listening to us during our YouTube and during our podcast listing.
Uh-huh.
what is your advice to young surgeons? How do they balance up their life? You know, in work, family, friends. How do you do it? How do you maintain your success there? And what is your advice to these people?
For me,
Yeah. What
well,
is your advice?
if you ask me these questions, I have to say sorry to my family. First, let me apologize to my family, because at the beginning of my career, I never spent a lot of time with my family. Usually
Yeah.
during the weekend, I have to make a roll around. I'll leave the kids in a van with my wife, and they will wait for me for 3 hours. And nowadays, I think a lot of scientific paper will tell you that if you work too hard, you don't have time to sleep. That will affect your performance. So for the younger generation, I think we're talking about work-life balance now. So, I mean, first of all, I think it's time organization. You have to organize your time well. And now I have to teach you within the limited of time, which is I'm teaching you in within a limited of time. So I have to find a different way of teaching you. So how do I think you have to rest, you have to play hard and work hard. Okay. During the limited time of working, have to concentrate. A lot of younger generation, they are not concentrating on what you're doing. Although the Y generation and Z generation, the concentrate period is very short. But during that short period of time, please put 100% of effort in it, and then you can relax. So this is my advice to you. But spend as many time with your family, or else you're gonna be regret like me. Yeah.
I think all of us, Prof, not only you. I think all of us have the same problem.
Yeah.
I think we all do. And I think we got another 5 minutes, Prof. I think I want to ask you this. What will be your legacy, Prof? And what would you want people to remember of you? What will be it?
Nah, I never
What would
think
be?
of this. I really never know. I don't think of this question. People wanted to remember of me, but I just make friends with everyone. People can remember me as an average surgeon who writes something that's very true. All my publication is reproducible.
Right.
Yeah, even on the basic research, I think it's reproducible. None of these were made it up. All of these were true. So if you follow, it's reproducible. And I wanted people to remember me. Well, a lot of people remember me when they play golf with me.
Very good second shot. Very good second shot.
I'll kill you.
Can I ask you one question?
Yes, please.
One of the friend gave me a question for you. Why did you shift back to Taiwan when you had the opportunity to work in the US?
Very good question. I'm a third child kid. I spent the first maybe 10 years of my teenagers were in the state. I graduated from grammar school to high school, graduated. I spent a little bit of time of college in the United States. Do I love the state? Yes, I do. But in the state, I don't think I have this great opportunity. I think stay in Asia, a bilingual. That's my advantage. If I go back to the state, I'll probably be like my sister and my brother. They are now practicing privately by themselves. And do I regret of not going back? do I wanted to stay at the time? I never have any second thoughts of staying in the state after training in the state. And I think I love my country and I love where I am and I love my school. So I think I have the loyalty to my school. So I need to develop my school or my university hospital. I wanted to bring my university into the role, and of course, I mean, I miss the life in the U.S. and now my kids are in the U.S. studying.
Right.
So,
Right.
do I miss U.S.? Yes, but I like the life of U.S., but I don't like the work life in U.S. I think it's very competitive, and it's not it's more competitive and sometimes racist.
Yeah. I think you've hit the nail on the head there.
Yeah.
Yeah. I think we've run out of time, Prof. 7
Okay.
p.m. So thank you so much for joining us in this ELSA TV 4th edition. And I had a good time and I hope you did as well. And Kyo, thank you so much for joining in and helping me co-host this. And we hope to see all of you in our next viewing. And we'll put this up on YouTube, and I'm sure Sajid will put it up on our social media, and I'm sure it'll get a lot of views. And any last words, Prof, before we call it a day?
Well, I'd like to thank ELSA for giving me this platform, even though now I'm on the top, and I really thank ELSA this platform, and I encourage all the younger generation of joining ELSA in Asia. I think ELSA is a good platform, not just academic, but social wise and as well as entertainment. And I think this is a very strong society under the guidance of all the board members. We are a strong society, provide very good platform for you to learn, for you to exchange ideas. So I encourage all the younger generation to come to ELSA and experience the friendship of ELSA. Yeah, this is my advice to the younger generation. And I also like to thank both the moderator for giving this time to chat a little bit, and I thank you truly from the bottom of my heart.
Thank you, Professor. Thank you so much.
Thank you.
Thank you, Kyo. I think, Kyo, you can end the session, Kyo. Is it okay?
Yeah, thank you so much for everyone watching this ELSA TV. ELSA, as Professor said, ELSA is very friendly community to support it among us, each other. So this is very good opportunity for everyone to join. Yeah, thank you so much. Thank you,
Gopur and Kyo.
Yeah.
Thank you very much.
Thank you so much.
you.
Take care.
I'll see you around. Yeah, bye. I'll see you in
Bye-bye.
Bali. Yeah.